So, good evening, everyone, to the second presentation in the clinical learning series. Today, we will be speaking about the approach to fever, which is the first part in discussing fever in detail. So, today, as a presenter, we have Dr. Srinidhi. Dr. Srinidhi completed his MBBS from Mahatma Gandhi Institute of Medical Sciences, Sevagram, and later on worked for about 1.5 years in Shaheed Hospital, which is a secondary care hospital in Balod district of Chhattisgarh. In addition, he is also involved with uh, many groups like Medico Friend Circle, uh, Umeta Foundation, etc. In this presentation, he is also being guided by Dr. Gajanan. Dr. Gajanan completed his MBBS from Government Medical College, Nanded, and a DNB in family medicine in Jan Swasthya Sahyog, Bilaspur, which is a 3-tier healthcare program running in Ganyari near Bilaspur in Chhattisgarh. He is currently working as a public health physician there for the last 8 years. And he has also completed his master's in public health from London School. He is passionate about rural health and development by the way of service, training, research, and advocacy. So with this introduction, I would like to request Dr. Srinidhi to take over and begin his presentation.
Thank you so much, Savitri. I will just share my screen. Give me a minute.
Sure.
Is it visible to all?
Yes. Yes. Go ahead.
Yeah. So, good evening, all. Thank you, Savitri, for giving the introduction. So today we will be discussing about a clinical problem that we regularly encounter in our day-to-day clinical practice, and that is fever. So why is it necessary to discuss fever? A patient may have a fever in mildest of conditions like a viral respiratory tract infection. Also, in fever, also we have to rule out certain red flag signs which have life-threatening underlying, which can have life-threatening underlying conditions. Fever itself can be a presenting complaint in multiple diagnoses. So it is very important to have a detailed history and examination, as we will be discussing in this presentation further. So as we have a regular approach with clinical learning series, as Savitri had done it in the PPT with snake bites also, we will be starting with a case and then we will see how to proceed from there. So we have a case here, that a case of 30-year-old farmer presenting with fever and chills since the last 3 days. So how do we go from here? So first of all, let us define fever. So what is the normal body temperature? So normal body temperature is 36.8 degrees Celsius plus or minus 4 degrees Celsius. In Fahrenheit, it is 98.2 degree Fahrenheit plus or minus 7 degree Fahrenheit. Generally, we can consider fever to be as a temperature, a core body temperature of more than 38 degrees Celsius, that is more than 100.4 degree Fahrenheit. What are causes of fever? So causes of fever, there are multiple varied diagnoses which can present with a fever. Most common cause of fever amongst all are the infections. There may be infections specific to certain locations like an abscess of an oral cavity or bones or joints, etc. There may be specific organisms causing fever like TB or HIV. There may be certain causes or diseases which are local to that particular area. Like if we consider Southeast Asia or India, we have diseases like malaria, dengue, which are endemic here. Some other causes of fever include connective tissue disorders and malignancies. So as we have studied in pathology, we will be discussing what exactly happens when we have a fever. So as we have seen in the causes, infections happen to be the most common cause of a fever. So whenever infections, microbial toxins enter our body, the early responders of the infection, that are the inflammatory mediators like monocytes, macrophages, etc., they release a lot of cytokines, which include IL-1, IL-6, tumor necrosis factor, interferons, etc. And these cytokines happens to be pyrogenic cytokines. Pyrogenic meaning they are the ones which cause a fever. Now, what happens at the hypothalamic level? Hypothalamus is basically the thermoregulatory set point of the body. Okay, so at this particular location, there is a release of lot of prostaglandins, E2 specifically, which elevates the thermoregulatory set point. So because of elevation of thermoregulatory set point, what are the other changes which occur at the peripheral level? So at the peripheral level, there is vasoconstriction and blood is shunted to internal organs. So that is why we can see there are two mechanisms by which the temperature is increased. That is one, increased heat production, or second, that is decreased heat loss. Overall, a fever in a range, in a particular range, is very effective in removing the pathogen from the body because it is promoting the activity of T cells and interferon. Now, before we start the history part of the fever, we are giving a classification of acute febrile illness. So acute febrile illness is basically a fever which is coming within 2 weeks, majority of which come within the first week itself. So whenever we get a patient with a fever, and first step we have to do is we have to classify it into acute localized infections, the one infections which are localized to certain organ systems like respiratory, urinary tract, GIT, etc. And the second major group of diseases would include acute undifferentiated febrile illness. So initially, let us first discuss about acute localized infections. So this is the way we are going to proceed from here. We will be taking a detailed history. We will try to shortlist some differentials on the basis of history and then proceed with the examination to confirm our findings of the history and perform some relevant investigations. We are starting with history of presenting illness. What are the points in history which can help us in diagnosis? So before we begin history or an examination, it is pertinent to note that there are certain red flag pointers which we have to identify very early. So if we have these red flag pointers and we are sitting in a, say, a primary care center like a PHC, we might have to act very quickly to stabilize the patient. And at times, we might have to refer the patient to a higher center as well. So in these cases, a detailed history is not warranted. Here we have to identify the severity of the condition. So what can be the red flag pointers, particularly in the history part? If the patient is presenting with a high fever or repeated rigors or in drenching night sweats, any feature of sepsis like severe pain or myalgia, if he is coming with an altered mental state, unexplained rash, or incessant vomiting. This happens to be certain points which are considered in history. These are the red flag pointers. In red flag pointers in examination, so if we get these findings within first initial time of the examination, we have to act really quickly. What are the different points here? If the patient is severely prostrated, meaning that he's unable to stand, sit, or walk without support, there is a very high grade of temperature, which is more than 41 degrees Celsius, or there is a very low temperature. In respiratory, there is decreased saturation, increase in the respiratory rate, patient is tachypneic, dyspneic, patient is having a low blood pressure or cold extremities, meaning he is in a shock. Neurological symptoms might be there, like altered mental status, a low Glasgow Coma score, or positive meningeal signs, which we'll be going to see further as well. So all these findings happen to be red flag signs in examination. And if we get all these signs, we are bound to act very quickly. So if the red flag signs are absent, so we are going to take a detailed history. And what are the pointers that points that we will be discussing in the history? So we are taking a complete history of presenting illness, starting from the presenting complaint that the patient has come up with. We will be trying to review all the systems and ask questions, ask negative history pertaining to each system so that we are able to localize the disease. We'll be trying to take a past medical history if the patient has got any operation in the past or he has got similar illnesses in the past. Has he put on any drugs? It may include antipyretics, antibiotics. Is the patient allergic to any drug? Is there any family history which is relevant, or a contact history, or a travel history, especially important when the patient is traveling to endemic zone of certain diseases? This becomes a very important history. Is there exposure to animals? Is there a specific history of taking a certain diet? Sexual history is again very important because there are certain infections which could spread by this particular route. So as we have discussed, the history is, we are trying to take a history to localize the fever to a particular area or an organ system. So these are the various locations, like a fever may get localized to the oral cavity, to the ear, nose, throat area, or a respiratory tract. It may be localized to a cardiovascular system. It can localize to hepatobiliary system or anywhere else in the abdomen. Apart from this, it can be a cause, fever can be a cause of a local condition, skin condition like cellulitis. So first of all, first question that we might want to ask our patient, since how long does he have fever? So as we have said before, acute febrile illness could be defined as fever less than 2 weeks, but most of the differentials present with a fever less than 1 week itself. Classification of fever based on duration. This is important to note. A fever can be acute if it is under 7 days, subacute if it is under 14 days, or chronic if it is over 14 days. Why is it important to note the duration of fever? Because there are certain differentials which we will be able to outline if we know the duration of the fever well. So under 3 days of fever, most likely is a viral URTI, but still we will like to take a relevant history for ruling out any other infection like a UTI or a pneumonia. Fever in between 4 to 14 days can be due to flu, dental infections, hepatobiliary tract, arthropod-borne infections, arboviral diseases like malaria and dengue, or a scrub typhus, etc. Protracted fevers are usually caused due to neoplasms. So subjectively, the other question that we want to ask to a patient is, how severe is the fever? So fever, he may say that it's a high grade fever or a low grade fever, but we can measure the fever and then we can put the classification out as if it's a mild grade of fever. The temperature might range up to 102 degree Fahrenheit. Moderate grade of fever temperature will range up to 104 degree of Fahrenheit. High grade fever will up to 106. So usually any fever which is caused by infection will not go beyond 106 degrees of Fahrenheit. But there is a condition that we will like to note at this stage, that is hyperpyrexia or hyperthermia, where the temperature can go beyond 41.1 degrees Celsius, that is 106 degree Fahrenheit. In this particular condition, the heat production of the body is much more than the heat loss capacity. Causes might include malaria, heat stroke, CNS tumors, and hemorrhages. What is a heat stroke? So heat stroke is where the temperature goes beyond 40 degrees Celsius and the patient presents with a hot, dry skin. Here, the treatment would include rapid cooling of the body temperature with water and using ice packs. Next question that we would like to ask is the patterns of fever. Now, this is classically very important because many diseases tend to be associated with a specific pattern of fever. But sometimes, because of rampant use of antipyretics, classical patterns of fever may not be visualized so easily in patients with a febrile illness. Still, it is good to note all these patterns. So number one pattern is an intermittent type of fever. Intermittent type of fever is where temperature remains above normal for a certain period and then returns back to normal. So example of this include many pyogenic infections tend to show an intermittent type of fever. Relapsing fever, classically seen in malaria, where fever returns to normal for days before rising again. So here in malaria, we classified malaria pathogens into different type of fever patterns. Like a benign tertian malaria can be seen with Plasmodium vivax. Malignant tertian malaria is seen in Plasmodium falciparum, where fever spikes are seen every 48 hours. Continuous pattern of fever can be seen in viral infections. Here, the temperature continuously remains above normal and daily fluctuation of temperature is less than 1 degree Celsius. Remittent fever, the temperature is always elevated, but fluctuations are more than or equal to 1 degree Celsius. Diseases which show such a pattern include typhus, sepsis, and tuberculosis. Step ladder fever is the fever where temperature ascends in a step ladder fashion, and it is seen in enteric fever. There are other fever patterns which can be noted, which include Bell-Epstein type of fever associated with a Hodgkin's lymphoma, periodic fevers, the patterns that repeat over months or years, relapsing type of fevers that we have seen in malaria. An undulant or a protracted fever is where temperature remains continuously above normal and daily fluctuations are more than 1 degree Celsius. So this is something we are trying to figure out with in the history. Other point that we will mention in we will ask the patient is about chills and rigors. Does the patient have chills and rigors? So chill, what is a chill? Is basically a sensation of cold, and this happens when the hypothalamic set point is suddenly reset to a higher temperature, and that is because, as we have seen before in the pathogenesis, it is because of the pyrogens. Rigor is basically a severe form of a chill, which is associated with dry mouth, piloerection, teeth chattering, severe shivering, and peripheral vascular shutdown. All these conditions can be seen in septicemia, pyogenic infections, malaria, abscesses, etc. What are the other symptoms associated with fever? So fever can present with a rash. So what are the various points to be noted when we talk about rash? So now fever with rash as a topic, I've talked with Dr. Mihika. She will be taking it in much detail when we will be discussing dermat, but still we will consider some relevant points here. So depending on the rash distribution, we have different differential diagnosis. Centrally placed rash will be seen in viral infections. A peripheral rash is usually seen in bacterial endocarditis. It is an important peripheral sign. Vesiculobullous rash with changing characteristics can be seen in a varicella infection. Certain infections also present with a urticarial-like rash. Rickettsial diseases present with an ulcer. Meningococcemia, it's very important. Meningitis can present with purpuric rash. Dengue can present with a maculopapular rash. It's a classical type of rash which is seen in dengue. So these are the images of the rash. As we can see, rash in the chicken pox, which is vesiculobullous type. Number 1 image showing maculopapular rash of dengue. Number 3 image is showing the purpuric lesions which are seen in meningitis. And number 4 are a classical urticarial lesions which are seen with drug-induced fever or certain other infections. There is a mnemonic that we would like to remember here. When does the rash start? With the number of days of fever. So the mnemonic says very sick person must take XX. So varicella, the first letter varicella. Here the rash is the first sign usually seen. Scarlet fever, rash occurs on the second day. Smallpox, historical to note, the rash used to occur on the third day. Measles, the rash occurs on the fourth day. Important thing to note with measles is that the diagnostic pathognomic sign of measles, that is Koplik spots, usually appear on the second day of fever. In typhus, the fever occurs on the fifth day. Rash occurs on the fifth day of the fever. In dengue, rash occurs on the sixth, and enteric fever, rash occurs on the seventh day from onset of fever. What are the other symptoms? If fever is presenting, the patient is presenting with a fever and headache. I apologize for going offline. I will start the screen again. Am I audible, Savitri?
Yes, you are. Continue.
Are the slides visible?
Yes, visible.
Yes.
Okay. So, where did I go off? I think I will start with fever with rash.
We were able to hear till the end of this slide, if I remember.
Okay, we'll start with fever with a headache. So, we discussed fever with rash. So, there may be other symptoms which may be associated with fever. We will be asking those as well. If the patient is presenting with with a headache, neck rigidity, or mental confusion, we will be suspecting meningism or CNS conditions like neoplasms. If the patient is presenting with fever and jaundice together, here we are suspecting conditions like leptospirosis, viral hepatitis, and malaria. Any other localized infection will show particular point in the history. So it is important to take history for that particular region as well. For example, an oral cavity condition might, the patient might present with fever and tooth swelling or a gum swelling or a pain in the oral cavity. Fever presenting along with dry cough, throat pain, difficulty to swallow, change in voice, etc. All these symptoms usually point towards acute upper respiratory tract infection like a pharyngitis or tonsillitis. Fever with severe ear pain, fever with an ear discharge point towards a ear infection, and it may be an acute suppurative otitis media or a chronic suppurative otitis media. Fever with a productive cough and a shortness of breath, that could be because of a lower respiratory tract infection or a pneumonia. It is important to ask for past history of cardiovascular disease because a new fever in a patient with cardiovascular disease could be endocarditis. Fever presenting with abdominal pain, diarrhea, nausea, and vomiting could be localized in the abdomen, conditions like acute dysentery, localized GI tract conditions, or a generalized peritonitis as well. Especially in females, young children, and geriatric patients, history of burning micturition is very important to be asked. That can detect a condition which is urinary tract infection. Many a times it can present as a fever. Fever with a localized limb swelling can point towards cellulitis. After having gone through all the points in negative history, we are also consider other points like what season is the patient coming in, because in rainy season, for example, arboviral infections like the diseases which are spreading through mosquitoes or rodents usually peak in a rainy season. Are there any potential exposures that we need to take care of, like insect or a mosquito bite, contaminated food or water, which we know is a cause for enteric fever? Is there exposure to body fluids or animal products? So here we are talking about a risk of leptospirosis. There are certain important risk factors like walking barefoot, a rural or a urban location of living location, paddy fields, and exposure to flash floods. So all of these are risk factor for a scrub typhus. Are there any specific pointers towards the patient? Like, is the woman pregnant, or they are taking any immunosuppressive treatment, or they are suffering from any immunosuppressive condition? There may be certain fevers which may be seen in those conditions as well. History of drug intake. History of drug intake is very important because, as we have seen before, it can cause a change in the pattern of fever. Also, a drug itself might be a cause of a febrile illness. So drug which can cause fever commonly include sulfonamides like sulfadizine, penicillins, anti-tubercular drugs, and certain anticonvulsant drugs. Here, as we have seen in the slide with fever with rash, the patient can present with a urticarial type of rash. There may be other conditions like a pruritus, hypotension, and arthralgia. So as we have discussed all the but important points that we need not miss in history taking if we are going for a detailed history of a patient coming with fever. Now we can go towards examination. So after history, we expect that we are ready with a certain set of differentials. And now it is time to confirm those in examination. So important factor here that we will be noting is that with every 1 degree Fahrenheit rise in temperature after 100 degree Fahrenheit, pulse should increase by 10 and respiratory rate should increase by 4. So an important point in examination is, we are talking about fever. So how to record the temperature? So very common sites of measurement of fever are, measurement of temperature are oral, axilla, and rectal. Normally, when we take the temperature at these sites, rectal temperature is always higher than the oral temperature, and it is more than axilla. So rectal, vaginal, and eardrum temperature usually reflect the core body temperature, basically meaning that it is a method to non-invasively measure the core body temperature of different organ systems, because it is not feasible in everyday practice to be able to measure core body temperature invasively. So rectal, vaginal, and eardrum usually reflect the core body temperature. And temperature measure in mouth or in axilla reflect the peripheral temperature. And peripheral temperature, as we can guess, is highly influenced by the surrounding environment. So method to accurately measure the oral temperature, we have to take the thermometer and place it under the tongue at the junction of base of the tongue and floor of the mouth. The ideal record time is 3 minutes. As for rectal temperature, it is very ideal to measure rectal temperature in babies and young children. There is a 3 centimeter in for 3 minutes rule. That means that thermometer should be inserted 3 minutes inside the anal verge and kept for 3 minutes so that we can accurately measure the rectal temperature. While measuring the rectal temperature, it is essential to not dig the thermometer too hard or hold rigidly or do anything that may cause damage to the baby. So what are the different pointers to be looked for in general examination? As we have discussed in fever in the first slide, that with every 1 degree Fahrenheit rise in temperature after 100 degrees, pulse rate should increase by 10. But sometimes there are certain conditions which present with a relative bradycardia. What it means that the pulse rate does not increase as much as expected. So what are the conditions? The conditions like typhoid, leptospirosis, and viral fevers present with relative bradycardia. Icterus. So we have already considered the diagnosis of fever with jaundice. Here we are going to confirm the history of jaundice by looking at visible icterus. When does the patient present with clubbing? Respiratory systems conditions associated can be bronchiectasis, tuberculosis, lung abscess, and empyema. Cardiovascular conditions like congenital heart diseases could also present with clubbing. Patient can present with a cyanosis if there is a croup or a pneumonia. So at this stage, we will be discussing peripheral signs of endocarditis. So here from head to toe, there are various signs which are to be noted in examination while we are thinking of endocarditis, which includes subconjunctival hemorrhages, petechial hemorrhages on mucous membranes and the fundus, poor dentition because the foci of an endocarditis usually come from the oral cavity. Splenomegaly, which happens to be a very, very common finding in endocarditis. There are certain other findings like clubbing, splinter hemorrhages, a rash, a very classical rash which is seen, a petechial rash, and other features pointing towards the cardiovascular system like varying murmurs. So changed murmur or a new murmur could be heard, and there is a history of cardiac failure or history of conduction disorder, etc. Other points to be noted is a fever with lymphadenopathy. So when does fever present with lymphadenopathy? The conditions might include leukemia, lymphoma, tuberculosis, and HIV. We look for a pallor. So fever presenting with a pallor. So there are certain infections which can cause hemolysis during their pathogenesis. So example is malaria. Patients sometimes present with a subjective fever of subjective feeling of a fever, or let's say fatigue or weakness, and when we evaluate, we can find nutritional deficiencies like iron deficiency and vitamin B12, etc. In endemic disease, in endemic states, sickle cell disease is a huge problem. Patient presenting in sickle cell crisis can have overwhelming infections presenting as fever. This stage, we will also discuss about an unique application called as Schwarz. This depends on general examination findings only. It's a tool designed to help trained frontline workers and caregivers, and this was used very well during the second COVID pandemic. That the caregiver can decide whether the person who is presented with COVID-like symptoms can be treated at home or needs consultation or needs an admission, and accordingly color criteria are given. These are very important if we look at people who are working with the communities in rural or tribal areas. And this was developed by Jan Swasthya Sahyog and Samanvay Research and Development Foundation. We will be giving the link to this particular application in our chat box after the presentation. It's good to have a look at it. General examination, we are going towards systemic examination. First, central nervous system. So as we have discussed, meningitis and classical history presented by a patient with meningitis, it is important to note certain meningeal signs also, because meningeal signs are a red flag pointers for us. There is an important sign called as Brudzinski sign, If in a patient who is placed supine and neck is flexed, lower extremities also tend to flex. This is Brudzinski sign. And second is Kernick sign. Kernick sign, when hips are flexed and knee is flexed, and in this position, if we try to extend the knee, it is not possible, and this is Kernick sign. So both of them are red flag pointers for us. In respiratory examination, we are looking at crepitations, egophony, bronchial breath sounds, all of them pointing towards pneumonia. In ear, nose, and throat examination, we are looking at the tonsils, we're looking at the facial pillars, we're looking at if there is a redness, if there is an exudation from the tonsils. We are looking at all the sinuses in the paranasal area. We're looking at any ear discharge or local examination of nose and the ear as well. At this point, again, we will be looking at a very important criteria, which is known as Centaur criteria, because many of the patients in OPD present with a sore throat and a fever, and it becomes important for us at that point to consider using antibiotics or consider not using antibiotics. So how do we determine that? So this is an important criteria which looks at age, exudation from tonsils, if the lymph nodes are tender or not, if there is a fever or if there is a cough. And depending on the score, we will determine if antibiotics are needed or not. Generally, an important differential in pharyngitis is streptococcus. So if the score is on the higher side, we will be looking to add empirical antibiotics for the same, or also go for a rapid streptococcus test. Moving forward,
just want to tell you about the time.
How much time do we have?
To take another 5 minutes.
Okay, cool. Yeah. So per abdomen examination, a fever presenting with a hepatosplenomegaly, important differentials would include malaria, infective endocarditis, Kala Azar, enteric fever. It could be also malignancy. There may be other findings in abdomen like a tender abdomen, lump in any quadrant, and there are certain diagnostic triads that we use, especially pertaining to conditions in the abdomen. Like acute appendicitis, we look at Murphy's triad, where there is a right iliac fossa pain, abdominal pain, right iliac fossa abdominal pain, vomiting. There is a Charcot's triad, which is indicative of cholangitis. The patient is presenting with fever, jaundice, right upper quadrant. Looking at, especially in the women, it is very, very important to take a proper history and examination of related to obstetrics and gynecology, gynecological examination, like looking for vaginal discharge, cervical motion tenderness, etc., because the fever might be localized to that particular organ system. So this is again a summarizing slide of where fever is presenting with localizing symptoms. We have different organ systems and different conditions localizing to that particular organ system. Like in the CNS, we can have a brain abscess, encephalitis, neurosurgical infections, endophthalmitis, meningitis. All of these may present with generalized CNS signs along with fever. In ENT, we can have sinusitis, pharyngitis. In lower respiratory tract, we have tuberculosis, a lung abscess, pneumonia, empyema. All of them can present with a fever. Similar conditions localized to different organ systems in abdomen can also be seen, and also localized conditions of the skin, bone, and the joints. All of these conditions usually presenting with fever and associated symptoms related to that particular organ system. So we have discussed a lot of fever, but and we have also noted that infection is the most common cause of fever, but there may be cases where despite of infection, fever is not present. So where can we see these conditions? In newborns, elderly, if the patient is malnourished, and if the patient is on immunosuppressant drugs. Right. So as we have discussed the whole presentation, this is again a summarizing slide where we are noting the importance of associated symptoms with fever. Fever with altered sensorium will go to CNS. Lymphadenopathy we can note in general examination. We have to ask for a decreased urine output. We have to ask for a history of past any illness, especially serious illness. All of these pertaining to especially we have to understand the importance of localizing the infection. So moving ahead, after having localized the infection, there may be certain conditions where the infection is not able to be localized, and we classify them under acute undifferentiated febrile illness. Definition is a duration of fever less than 2 weeks where no organ specific symptoms are present and the patient initially presents with generalized symptoms like headache, chills, or migraine. The mnemonic for acute undifferentiated febrile illness is MAESR. These are the 5 main disease groups that can cause an acute undifferentiated fever. It includes malaria, arboviral infections like dengue, chikungunya, enteric fever, spirochetal infections like leptospirosis, and rickettsial infections like scrub typhus. So there are important pointers to consider in examination for these particular conditions. So for malaria, we will be doing a rapid diagnostic test and initially rule it out, or with a thick peripheral smear as well. For scrub typhus, we have to look for an eschar, which is a skin lesion, usually not associated with pain, pruritus, or edema. In leptospirosis, we can look at certain pointers like conjunctival suffusion, muscle tenderness, or a jaundice. Dengue presents with a rash and polyarthritis. Figures for those. This is the on the left hand side we can see a classical eschar which is seen in scrub typhus, and subconjunctival hemorrhage is seen in a patient of leptospirosis on the right hand side. These are the diagnostic signs which are seen in dengue. This is a maculopapular rash, and examination finding that we usually do is the tourniquet test to see for capillary fragility. A fever and unregulated fever can cause complications to different organ systems like CNS, liver, can cause coagulopathies and acute kidney injury. So for monitoring a patient of fever, it is important to evaluate for GCS and observe, evaluate for AST-ALT values, subjective improvement, look for any new signs of bleeding, continuously look for blood pressure, pulse rate, etc., and also look for urine output. After completely doing all the history and examination, there are certain fevers which even now are not able to easily localize or be diagnosed. So these come under fever of unknown origin. Common causes of these include infections. Certain infections come under FUO, malignancies, and there may be some immunogenic causes also. But point to underline is that we have to do complete history and examination in all cases of fever so that we don't miss the serious conditions. Recurrent fever and approach to recurrent fever is seen in this slide, that when a patient is presenting with a recurrent fever, we have to again reassess the condition and look for additional points in history or additional point in examination which we might miss, and this may help us to probably localize the fever or and treat or investigate appropriately. These are the references. Thank you so much. This presentation focused mainly on history and examination part. Relevant investigations and management part will be duly dealt in the upcoming series. Yeah. Thank you so much.
Thank you very much, Sri, for the very comprehensive presentation. Now I'd like to request Dr. Gajanan to add, and also we're very happy to have Dr. Anurag Bhargav with us today, and I'd also request Gajanan to introduce him to our audience today.
So good evening all. Srinidhi has done very wonderful presentation, and I think main point to learn here is importance of history and examination. And in about 80 to 85%, and even more, like 90% of the fevers, the diagnosis will be revealed by history. And if we know the local endemicity of the causes of fever, and they will give us diagnosis, especially in the rural areas where investigations are inaccessible and they are costly. If we see in cities, there are tests called fever panel where all the tests are ordered. But if we can narrow down the list of differentials with detailed history and examination, there are a lot of pointers in the history and examination which can narrow it down. And thank you, Dr. Anurag sir. You are here as an expert, and I think he will be the best person to emphasize the importance of history and examination. I have nothing more to add. Over to Dr. Anurag.
Am I audible?
Yes, sir.
You are.
Yeah, so thanks, Srinidhi, for that presentation as well as for the invitation. In fact, I just want to maybe give certain weightage to certain parts of your presentation. So let me put it this way, that the golden rule in medicine is that there are no golden rules in medicine. So, for example, Srinidhi has outlined the different patterns of fever in malaria, for example. But the caveat is that these fever patterns do not get established in the initial few cycles, and it may require some days before the cycles get synchronized to give you that tertian pattern of fever. So first thing is that although we emphasize certain things, you may not see that particular pattern in your patient. But nevertheless, one of the main points in the history as firstly, when we ask for symptoms of respiratory tract involvement and GI involvement and genitourinary involvement, or even CNS and this thing, then we are able to localize the infection to a particular organ, and then we are on a firmer basis on what is to be done with the patient. But the other problem is when people have just fever with myalgia or headache and some nausea, vomiting. So this is the group which poses the most diagnostic issues, for people, because if somebody has clearly diarrhea and some blood in stools with fever and abdominal pain, then the diagnosis is relatively clear cut. But what do you do with the person who has a fever with just general non-specific symptoms, not indicating any particular organ involvement? So this is the group which is undifferentiated, acute undifferentiated fever. And this is the group which occurs in countries like ours, and which contains all the tropical endemic infections. And for us working rural areas, this is very important to understand, because these are also the infections which occur in outbreak situations. So you are not likely to see only one patient with this, but a number of patients presenting similarly. So Srinidhi has I thank him for quoting some of the slides, from our paper in BMJ on approach to acute undifferentiated fever. And this there are really 5 groups of illnesses here. And the first, easily just show that slide maybe. Yeah. So there is a particular logic to the sequence also. So malaria is easy to exclude on the smear and maybe a rapid diagnostic test. Arboviral infections can be suspected clinically because of, for example, chikungunya. Somebody will come with arthralgia. Dengue may have a rash, but often the clues are also on the basic test, which will probably be dealt with later. But apart from malaria and arboviral infections, where you can establish the etiology, arboviral infection like dengue, you can get an NS1 done. But for these ESR pathogens, the confirmation is difficult to do. For example, enteric fever, the confirmatory test is a blood culture, which may not be available. Vidal is very non-specific. And the last two are the bacterial zoonosis. Now, these are the most common infections which we are actually missing. So we are not suspecting scrub typhus enough, because the name is a misnomer. We think that it will occur in only people who are living near forest land, but you can get the bite of the mite even in your kitchen garden or your lawn. So rickettsial infections now, for the last few years, they have been found to be prevalent all across India, and these also occur in the same kind of rainy post-monsoon season. So the typical occurrence seasonality of scrub typhus is from July to December in North India. So anybody coming with an acute febrile illness, where dengue has been ruled out, malaria has been ruled out, and this person is febrile, we should strongly suspect scrub typhus in these patients, because it is a very common thing. Now, in fact, a multi-center study showed that after malaria and dengue, actually scrub typhus was almost as prevalent as dengue in a 6-site study. So scrub typhus is not being suspected and not being thought about. And I'll just give you some more information on that. Spirochetal infections, again, leptospirosis, we are seeing all the time. And again, it's a low index of suspicion. that leads to this situation. And of course, there are problems with the diagnostic confirmation. So when it comes to the history, we has already outlined the thing. So I would say that one more point that I should say is acute undifferentiated febrile illness may start with only fever, but may show an organ involvement later on within the first week itself. So for example, somebody has 2 days of fever, and third day he is becoming develops altered sensorium. This could be cerebral malaria. So although it may start with an undifferentiated fever, very quickly this may become an organ involvement with CNS involvement. Similarly, with scrub typhus, what we see is rapidly they may have very dry cough, but within 1 week, many times they develop bilateral pneumonia progressing to ARDS. Similarly, you can have leptospirosis presenting with jaundice and acute kidney injury and acute renal failure. So these are not differentiated at their point of onset, but they can develop rapid systemic involvement, and that is what is sort of so troublesome about these illnesses. So in the history, I would say, apart from the pattern of fever, I think epidemiology is the first thing. In fact, in the BMJ paper, we have put an emphasis on epidemiology. Epidemiology means what is the season in which the fever is occurring. So if you have fever with rash and myalgia, arthralgia, again in the classical dengue season, you will be thinking about it. But often the seasonality overlaps in these infections, so it may not be completely diagnostic. But if you are getting somebody in the dry season, then these infections are probably less common. The other thing is we have to know what are the local prevalent infections which occur in outbreaks. So if your local medical college is seeing scrub typhus, then you start suspecting it. And if there is again, for example, leptospirosis would classically occur again with flooding, which is being seen across India now. So those are the kind of epidemiological things which create the thing for exposure. One specific thing which we are now never thinking about is the exposure to not only, for example, he said about walking barefoot in the farm would expose it to mite bite by scrub typhus, to spirochetal infections, but also livestock. And in the context of this, brucellosis is far less suspected and diagnosed than it is actually prevalent. So we have seen many patients with brucellosis in the last few months, where the exposure is that they are keeping goats and the goat has delivered and they are delivering the placenta, burying the placenta after the delivery with their bare hands. So brucellosis is an important cause of PU in India, especially in rural areas, which is again not suspected. So what is the occupation of the person? Somebody may be running a slaughterhouse and slaughtering animals. Again, they can get exposed to this brucella in that sense. Very, very important thing is what is the evolution of disease in the how rapid is the progression. So if you're getting a very sick patient in the first week of illness itself, think of dengue and malaria and leptospirosis and scrub. Enteric fever doesn't usually present with complications the first week. The complications are more in the second and third week. So if you have a patient who's sick with a fever which started as an acute undifferentiated fever, think of scrub and this thing. The pathognomonic feature of scrub, and maybe I can share some slides here, is the eschar. So eschar is as Srinidhi pointed out, is a painless ulcer which develops at the site of the bite. And this is okay. I've got many photographs of my own here from our experience here. So this is classically seen in hidden areas. You'll have to seek the eschar because there is no pain and itching. The patient may not point it out. So you have to carefully examine the neck, the armpit, the axilla, the groin. And the first patient of scrub typhus in Mangalore we diagnosed when we separated the gluteal cleft and found that there was an eschar there. So you have to really, if you spend 5 minutes, if you teach your nurses to look for eschars in these areas which demand some privacy, you can establish the diagnosis in Indian condition with an eschar. An eschar is present almost with this duration, the onset of fever. So I would correct his slide of it doesn't appear on the 6th day. The eschar is there on day 1 because it's where the entry of the organism has occurred. In some patients, the necrotic black part will fall off and you may just get a shallow ulcer. So an eschar is something we should really try to see. And whenever we have taught people to look for eschar and they start picking up an eschar, they really, start reporting a lot of it. So it's a very, very helpful sign of scrub typhus in India. And of course, it can occur with other rickettsial infections also. Leptospirosis, again, muscle tenderness. When you squeeze the calf muscle and the person is really shouting, that's an important sign of, which can occur in leptospirosis mostly. But it is often this thing, you can see in the eyes, the conjunctival subfusion and the jaundice. What I would again maybe finally end by emphasizing is that there is a lot of overlap between these various illnesses. And so that, you can have jaundice in malaria in the eye, you can have jaundice in scrub typhus, you can have jaundice in leptospirosis. So they are not, you have to keep the differential broad and look at the other things in the picture. But to conclude, I would say, look at the features that, the historical features, if they're pointing to localized infection, investigate them. One pointer here is, which is useful in all patients, is many patients with pyelonephritis will not present with dysuria or frequency. So in any case, like malaria, we're excluding an acute differentiated and undifferentiated fever. One important thing again is to exclude UTIs. So UTIs may not classically present, and it's always good to do a urine examination in an elderly diabetic to first look at possible UTI there. And if you get plenty of pus cells, then you should proceed on that pathway. So these are not absolute things, not everybody with localized infection may present with this. In rural areas, I would also point out one very serious infection which can kill very rapidly or, threaten the, limbs viability, and that is necrotizing fasciitis. So necrotizing fasciitis is, if people are not, aware, it may just look like cellulitis, but when somebody has a lot of spontaneous pain with cellulitis, not tenderness, but spontaneous pain, and you have, discoloration over the underlying skin and presence of bulli, then this is a patient who is likely to have necrotizing fasciitis, and, things should be done rapidly in terms of, even surgical debridement, and otherwise the fasciitis can really spread very rapidly. I will leave it here. So I just want to say that many of these illnesses are not suspected like scrub and lepto, but are there. They have overlap in epidemiology. They may occur in the same, season, but they can be distinguished. And amongst the findings, I can also say this much. This is something which is useful. Some of these findings are non-specific in themselves. So I would like to point out that there's nothing classical about the macropapillary rash in dengue. But when you have a patient with fever and rash, it almost excludes malaria. So the rash, which is non-specific itself, may help you to exclude, malaria, for example. And rash can also occur in lepto and scrub. But in the frequency, it will more occur with, dengue. Similarly, if you have, overt bleeding manifestations in a patient with fever, then it's more likely to be dengue. You have bleeding gums, it's more likely to be dengue, although thrombocytopenia may occur in many of these infections. Lymphadenopathy by itself, again, does not occur in malaria and is uncommon in enteric fever. So if you're suspecting whether this patient could be scrub, lepto, or enteric fever, the presence of lymph node enlargement will, orient the diagnosis towards scrub rather than enteric fever. We don't see rash with enteric fever at all commonly in India, so that is really not very common at all. If anybody, if you want to see some more eschars, I can show you, if you allow me to share the screen.
You can share your screen, sir.
Yeah, just a minute.
Meanwhile, I would just like to briefly introduce Dr. Anurag for anyone who may not know. Dr. Anurag is one of the founders of Jan Swasthya Sahyog. He is currently working as a professor in the Yenapoya Medical College in Mangalore. And he's also involved with a very important clinical trial, which is looking to establish the importance of nutrition in management of tuberculosis. Sir.
Yeah. Thank you, Savitri, for that introduction. This is just the value of index of suspicion. So this has been sent to me by one of our postgraduate students working in an area where there was never scrub typhus reported earlier. So 20-year-old with fever of 5 days being treated as typhoid at Gadag, and Shambhu, who's our postgraduate student, who is now assistant professor there in Gadag in central Karnataka, found this classical eschar. You can see the central necrotic scab. It is as if you have burned the skin with a cigarette burn. Can everybody appreciate it? So this is actually one of our first patients in Uttarakhand, where actually we have reported a large outbreak of scrub typhus in 2016. It was reported, but the outbreak was in 2012 and 13. So just skin examination is so important. This patient was not responding to ceftriaxone for a pneumonia, which is bilateral, and scrub typhus was never suspected. And we can see here, just if you remove the, we asked him to loosen his pajama, and there this thing was, sitting there, the eschar. You can see the central eschar, the back necrotic area, black necrotic area with an erythematous halo. A patient who was progressed to ARDS. Now this patient is on a ventilator, just imagine. And she had a prominent lesion on the abdomen, but it was never noticed by the treating physicians nor interpreted. And in these patients, if the eschar had been noted and you had started doxycycline, then within 2 days the patient would have improved. But she had progressed into ARDS, and ARDS, as you know, can have a very high mortality. This patient, again, all these undifferentiated fevers can present with different system involvement. So they can present with respiratory system presenting like a pneumonia and ARDS. They can present with hepatic manifestations, with jaundice, with renal manifestations, acute kidney injury. They can have an acute encephalopathy syndrome. For your information, a lot of the acute encephalopathy syndrome in Gorakhpur, for example, like acute encephalitis is not actually Japanese encephalitis, but scrub typhus. So this patient presented with altered sensorium in Uttarakhand with recurrent seizures. He had a high TLC, platelets were low, ASTLT were high. And when I removed his shirt, the collar, you see that eschar is sitting right there. This is the eschar. So please, as a kind of feedback from this, and again, it's about 1 centimeter. This is again one of our patients, a classical eschar. Of course, there can be other less common conditions which can be noted with an eschar, but they have different characteristics. Now, this is another thing which can happen, which another kind of rickettsial infection, and that is a kind of a retiform purpura. This is Indian tick typhus, but I'll stop here. Yeah. Any questions? Yeah.
Thank you, Dr. Anurag. From the chat box, there is one question by Dr. Milind Wankhade. How to manage shivering without fever? Would you like to elaborate on that, Dr. Milind?
Ma'am, I have experience. Can my voice
yeah,
getting heard?
Yeah.
I have experience in my OPD, ma'am. Patient come with shivering, and after at the time of shivering, he doesn't has pyrexia, but and he suddenly feels as more muscular contraction and teeth shivering, and followed by after 10 to 20 minutes he gets fever, high grade fever. So how to manage shivering without fever? When he come with our OPD, then he only has shivering, not at pyrexia at all. My question. Hello.
Yes, sir. Would you like to briefly tell where you're working, sir?
I have working as a medical officer as a Muktai Nagar from Jalgaon district, Maharashtra.
Okay. Dr. Gajanan, would you like to answer?
Yeah. So I think what is being described is the pyrogen acting on the body. So it is causing shivering initially, and which later on will cause fever. So I would say the management here is we have to treat the underlying cause. I see a lot many practitioners. I do get patients which are being referred from outside, and they do give dexamethasone to control the shivering. I would say not to do this. We'll have to treat the cause and use antipyretics. So use paracetamol and ibuprofen. That will control the shivering as well as fever.
Okay, sir. There is also some practitioner refer to chlorophenamine or injection Avil to control shivering. Is it relevant?
So main pyrogens, I think they are prostaglandins, and ibuprofen, which is antipyretic as well as it blocks these prostaglandins, will be the best. So CPM is another way to block the histamines. So they are acting in the same way, but the advantage of ibuprofen is it also has antipyretic action.
Okay, thank you, sir. Only paracetamol or ibuprofen is sufficient to manage
So
shivering.
you can do it in a step wise manner. So first start with paracetamol, but currently what epidemic we are seeing in Maharashtra or here in Chhattisgarh also. So most patients fever are not being controlled with paracetamol. The reasons are first is underdosing of paracetamol. So what we are seeing is paracetamol 500, which is in the essential drug medicine list, and then the Dolo 650, which has become popular. But both of these are underdosing. Because the dose of paracetamol is 15 mg per kg per dose. And if someone is 50 kg, the dose will be 750. So that will require 1.5 tablets of paracetamol and every 6 hours. So mostly we underdose the patient. So that is the reason for no response to shivering and then fever. So first proper dosing paracetamol with proper timing. And even with that, if fever is uncontrolled, then I would go for ibuprofen. So dose is 10 mg per kg 8 hourly. So that will control it. And obviously the treating the underlying cause, because this is just the symptomatic treatment.
Okay. Thank you, sir.
There's one more question about the cutoff for fever while recording axillary temperature.
Yeah, so we can find different cutoffs here because there is variation in core body temperature and peripheral temperature. So I would say for peripherally 100.2 degree Fahrenheit is the cutoff we can use, and core body temperature 100.4, that is 38 degrees Celsius.
Dr. Pandurang, would you like to, sorry. Okay. Dr. Pandurang, would you like to unmute and speak about your comment that you just posted on the chat box?
Yeah, actually, I was committing the same that usually the literature says that 10 to 15%, or some literature says up to 17%, the eschar is visible. So in our last time also we had a presentation by Anurag sir, and we have huge patients of undifferentiated fever in the same area of June to October in Shahid Hospital. So we have kept track of almost 100 patients who were positive for scrub typhus on kit base. Out of that, 83% is our sensitivity rate of that kit, which we confirm from AIMS after ELISA. So I would like to mention that the only 5 to 6% patients were there who we could found the eschar. There is a high chance that we miss it, but we have literally seen 2-3 doctors. We have seen all the hidden areas of that patient. So I would like to ask this question to Anurag sir, that this situation is making very challenging for us to make it confirm.
Okay. So thanks for that question, Pandurang. And in different areas of India, first of all, the frequency of eschar has been reported differently. So we found 17% in Uttarakhand, and but the Vellore people have reported almost 50% of their patients have eschar. I would like to say that people who have primary infections of scrub, who are developing scrub for the first time, as an infection, they are more likely to have eschar than people with secondary infection. So in some areas in Uttarakhand where we did a seroprevalence survey, again, in those patients, we found very few patients with eschar. The value of eschar is not in the sensitivity of this test. It may be variably present, but when it is present, then it has a very high predictive value for scrub typhus. That's what the thing is. So a lot of the times I would agree, you would have to keep scrub in the differential even if the eschar is not there. And but if you find an eschar, then you can be reasonably assured that this is scrub and it will respond very well to doxycycline. What has been your the other thing is, what I wanted to tell you is, if your denominator is 100 patients, all of which were positive, then a lot of patients with scrub typhus will be negative on serology in the first week. So I just would like to know what happened to these patients. Were they treated as scrub and did they improve, or you did not have a response? These patients who were positive on the kit for scrub typhus, did they respond to doxycycline?
Yes, sir. So almost all of them responded to doxycycline. We give both ceftriaxone and doxycycline. So
Okay.
and they responded to doxycycline. Yes.
So we can take up this issue of positive serology maybe later, because it's an important point. So I'm just saying that you can have both false negative serology as well as false positive. So it can be false negative in the first week of illness. So you may have some patients who are neither positive in the kit nor do have eschar, but who have scrub typhus. And in some patients, you can have a false positive also serology for scrub typhus because of long-standing antibodies. But we can discuss this on some other occasion. Yeah. But if they responded well to your antibiotic therapy, it is possible that you have genuinely a low sensitivity to eschar in your population. But I would still say that it's a good thing to train yourself and your staff in, because if you manage to see an eschar, then it makes the diagnosis almost confirmed. Yeah. Yes, sir. Like we have also had a similar scenario as you explained, that there is neither eschar is there, and both leptospirosis and scrub both were negative on our kit, and even the AIMS, despite of that, we sent to AIMS and they also reported as negative. But the patient response, and in such cases, in case patients have jaundice and other or like lab findings which are highly likelihood of some rickettsial or scrub infection, we treat them with ceftriaxone and doxy, and patient response. So it becomes a dilemma. Yeah, so I think the confirmation of diagnosis is challenging. We have actually developed a PCR here for scrub, which helps to diagnose these patients in that first week of illness. But the clinical point is, if you're suspecting scrub rickettsial infection, you should initiate therapy while sending for investigation. Do not wait for any confirmation, because you may lose time, and every one-day loss will increase the chance of complications drastically. So in a rural situation, you can send your test, but if other acute infections, localized infections have been ruled out, you are seeing something which is compatible with scrub or leptospirosis, then initiate therapy. And this is a worldwide recommendation, that you should not wait for confirmation of diagnosis. And definitely the serology is not confirmatory. Yes, thank you, sir. Thank you.
I had a question. During the COVID pandemic, we had seen certain patients who were COVID positive, but were also having co-infections of scrub, sometimes lepto, etc., and even malaria. So what is the importance of these co-infections, and how do they interact with each other, especially given that COVID is a new infection that we're dealing with?
Gaja, do you want to answer that, or should I go ahead?
Yes, sir, you can take it.
So Savitri, thanks for that question. And the issue is that most of these are not co-infections, but presence of antibodies to more than one organism in the same patient. So I would not call them co-infections unless this thing. So we are jumping the gun a bit because we were talking of only history and examination, but now that you have brought it up, so the only way to confirm an infection is either to show the presence by a direct microscopy or a culture or a PCR. So without a malaria smear, for example, really positive, you cannot diagnose this thing. Or without a blood culture, you cannot say you have diagnosed enteric fever. So when serologies, multiple serologies are present, for example, if you are exposed to dengue and you develop a mild infection, that IgM will be there in your system, and that IgM may persist for a few months after exposure. Similarly, if you're a farmer working in a field getting bitten by a mite or getting exposed to leptospira, then those IgM antibodies will also be there in your system for some time. So when you see a patient with coexisting antibodies to say dengue and scrub, then this may be three things. So some of the infections show cross-reactivity. So that is one possibility. It is just a cross-reactive response. Secondly, there have been recent infections and exposure for which the antibody is just present there. If you want to say that this is co-infection, then based on serology, that is IgM, the only way you can show it is initially somebody was negative for scrub and now has become IgM positive. So that is not the scenario that you are seeing. You are seeing a patient with possibly confirmed COVID-19 and who has antibodies in his blood for this thing. So they usually are just long-lasting antibodies due to previous infection. They have nothing to do with the current infection. If you want to say on the basis of serology that this is a co-infection, then you have to either prove that somebody was negative on IgM earlier and has become positive, or you have another sample repeated after 4 weeks and you show a 4-fold rise in titer. Just this coexisting serological positivity doesn't mean co-infection. And I think this point is unfortunately ignored. There are a lot of people who are now reporting, coexisting malaria scrub and dengue or malaria scrub and lepto. These are all actually not genuine co-infections here. But co-infections are reported, for example, in scrub and lepto because they get infected by the same exposures. So scrub and lepto can be co-infected. There could be co-infections, and as Pandurang has said that when we give ceftriaxone doxy, actually it addresses both these pathogens also. I hope I've addressed your query.
Yes, sir. Thank you very much.
It's a lab artifact, yeah.
Yes, sir. That's what I understand. Would anyone else like to comment or ask the question?
Hello. My question is, what is the significance of C-reactive protein in fever?
Okay, so C-reactive protein is an inflammatory marker, and it predicts, it can help differentiate bacterial from viral fever. Different machines have different cutoff. What we have here is less than 10 is normal, 10 to 40 it can be both bacterial and viral. And if it is more than 40, it can be bacterial infection. It goes more in favor of bacterial infection, but COVID is a outlier here. COVID causes a lot of inflammation, and especially with inflammatory syndrome or inflammatory stage of COVID, it can be very high. So CRP, I would say, predicts inflammation more than infection, but it can be used to differentiate. It can be used to see response of antibiotics when we are giving during treatment in monitoring if there are no other inflammatory things ongoing. That maybe we can discuss this in the next session of fever, where we can discuss investigations more.
Sir, I have experience.
Sorry, your question is not
CRP is 40, 45 in these days.
So here I would say epidemiologically there is a viral epidemic that is going on. So 40 is mostly a viral infection. If you are asking specifically in the context.
Okay.
Can I just add one more thing, Gajanan, to this group? Hello.
Yes, sir.
I would just suggest that everybody develops a routine when you're seeing a patient with fever, so that you're assessing the general appearance of the patient, the toxic look, and then systematically you're assessing the vital signs, which will, again, if the vital signs are showing any red flags, then you will immediately consider immediate management also. And then do a regional examination, which includes both for undifferentiated causes as well as the localized infection. So when you're looking in the eye, you can just look for icterus, but also look for conjunctival suffusion. It will help you. Oral cavity, also look for dental infection. You look for sinus tenderness in that area. When you're looking at the neck, we look for lymph nodes, but also look for meningeal signs. So if we develop a routine which is a regional, based on the regional examination, we are less likely to forget this thing. And everywhere we are also examining the skin. So if you follow the regional kind of examination routine and incorporate these features, so when you're looking at the lower limb, you're looking for edema, other things, but also look for calf tenderness there. So such a routine will help us pick up any of these infections. And it can be quite cost effective in terms of time. So you're examining the abdomen, just do not forget to examine the renal angle tenderness for pyelonephritis or suprapubic tenderness, apart from liver and spleen enlargement.
Yeah, I would reiterate this, like examining and history taking is a habit. And if there is a pattern, it is quick and also narrows differentials a lot narrow than what we see. And also we can advise specific investigation, saves a lot of cost to the patient as well as time.
Okay. Thank you, Gajanan, and thank you, Anurag, sir. With that, I would like to come to the end of this session. And I would particularly like to thank Anurag, sir, and Gajanan for taking your time and guiding us. And I would also invite Dr. Anurag, sir, for the further sessions of the clinical learning series. We feel that your presence would be very helpful for us. And I would like to inform that the next session would be held tentatively on the coming Friday, that is the next week. The topic, the speakers would be informed on the group. I request all of you to fill the feedback forms that we have, whose Google link has been shared in the group, and give us a detailed feedback of what you think. Thank you all for attending and taking the time. See you all next week.
Thank you, Savitri, and thank you, everybody.
Thank you.
Thank you, Gajanan.
Thank you, sir.
I can just speed Anurag or Dr. Anurag. I think that sir is becoming a little formal for me anyway.
Yes, sure.
Yeah.